you introduce yourself. Samasa Vaidya Shikshya, Maputta, Pasitya Kala, Parishtakala, Ramak Land. You will even say that. Right? It's okay. Now you should correct yourself. Okay? Hereafter you can't. Now you have to teach everything. I'm not going to teach the rest of the group Carpal. Okay? It's your duty. What is starting me to? Kiri better than the bitter of the question. Ridden. රිදන එක හිරිවැටිල්ල උඩේ නම් පල්ලෙහාට එනවද නැත්නම් මෙතන විතරක් තියෙන්නේ? හිරිවැටෙන එක කොතනද? ඒ ටික විතරයි තියෙන්නේ. කැක්කුම කොහෙද තියෙන්නේ? කැක්කුම මෙහෙ. එහෙනම් පල්ලෙහාට එන කැක්කුමක්ද? එහෙම මේ ටික රිදන. බෙල්ල කැක්කුමකුත් තියනවද ඒත් එක්කම? බෙල්ල හිටපු ගමන් කැක්කුමක් එනවා. කැක්කුමක් තියෙනවා. ඔව්. හරි. එතකොට මේ කැක්කුම වැඩි කොයි වෙලාවකටද දවසේ? නිදියන් ඉන්න වෙලාවට ඉන්දියානු කැක්කුම වැඩි. කැක්කුම අත යට කරගෙන ඉන්න වෙලාවට කැක්කුම වැඩි. එතකොට දවසේ වැඩ කරගන්න මේකින් ප්‍රශ්නයක් තියෙනවද? මොනවා හරි දිනදා වැඩ කරනකොට පොල් මිරි ගන්න අමාරුයි. නෑ එහෙම අමාරුවක් වෙන්නේ නෑ. කෝපයක් අල්ලන් ඉනෝ රිදනවද? නෑ. අඬු කෝපයක් අල්ලන් ඉන්න. නෑ එහෙම නෑ. බස් එකේ පොල් අල්ලන් ඉනෝ? එහෙම. රිදනවද? ඔය හරි බෑග් එක අරන් යනකොට. හුරු අත මොකද්ද? වම් අත කිව්වනේ හුරු අත. ඒකත් හුරුයි මේකත්. හුරුයි ලියන්නේ කරන්නේ වම් අතින්. වම් අතින් කබ්බන්නේ කරන්නේ මේකෙන්. කීයක් ගන්න මේකෙන්. එතකොට මේක දැන් කොච්චර කාලයක් තිස්සේ තියෙනවද? දැන් අවුරුදු 3ක් විතර වගේ ඊට වැඩිම තියෙනවද? එතකොට මේ තයිරොයිඩ් අමාරුවට තයිරොක්සින් පෙති ගන්නවද? උදේ පාන්දර ඉස්බර බොන්න ඕන පෙත්තක් ගන්නවද? ආතරයිටිස් අමාරුව තියෙනවද? කලින් මොකද වැටිලා අත බින්ද අස්ති බිඳිලා හින්දු මේ තියෙනවද? ගල් බැන්ඩේජ් දාලා තිබුණා? එහෙම මොකුත් නැහැ. මම පොඩ්ඩක් පරීක්ෂා කරලා බලනවා. වෙන මොකුත් මසනීප නැහැ නේද? Cholesterol. So now it took only less than 30 seconds. If you are ready to ask the question, you have to ask what is the complaint, whether it's pain or numbness, whether it's radiating pain from the neck downwards, because you can't say you are given a carpal tunnel case all the time. You can be given a radiculopathy, cervical radiculopathy, cervical rib. How do you know? You never know. I don't go with the idea hand. It's carpal tunnel. No. What if it's the ulnar nerve blocked at the Guyon canal? There's a called Guyon's canal. GYON. Guyon's canal. So ulnar nerve can be compressed at the Guyon's canal. So it could be anything. So don't go with that idea, right? So pain, numbness, whether it's a radiculopathy, and where is the pain, the duration. Good that you ask about the hand dominance. Right? The 1 mark is given for smiling and the hand dominance. Right? And then about risk factors, diabetes, hypothyroidism, arthritis, past history of fractures, all these. You might not be able to ask all, but if you are ready, you can ask. Then you examine the hands on a flat surface. If there's a pillow, use it. First is what? Inspection. Then mata pena metana මේකක් නෑ කියලා. But you know you are dramatizing something. Looking for scars. Sometimes it can be recurrent carpal tunnel. Right? Because if this is the previous surgery scar is incorporated into the what do you call these lines, you will not see it unless you look for it. Right? So you look for, and you always compare. Right? You can't disregard this, and paired organs always compare. You want me to go running commentary? Right. So on examination, on inspection, there are no obvious scars suggestive of previous carpal tunnel decompression. There are no other scars in the vicinity. There is no dorsal guttering. But you notice, there is obvious thenar wasting. So you compare that. If you look like this, it is not that obvious because you are looking from the front view. But when you do this, see there is obvious thenar wasting. So there's obvious thenar wasting on the right side, which is the non-dominant side for her, and there is no dorsal guttering. So that is my inspection. Then comes the palpation. In palpation, you have to check both sensory and motor for all nerves, because I don't know whether it's carpal or not. Right? Just because I ask you to come and do class check, make karani ye wenna. Hard. So what are the nerves? Median, ulnar and radial. So median nerve is what? Mana supply karani. All the thenar muscles except all the thenar muscles, but all the muscles of the thumb except adductor pollicis. Adductor pollicis is not a thenar muscle, but is a muscle of thumb. Agree? So out of the thenar muscles, which one is solely supplied by median nerve? Okay? Out of the thenar muscles, which muscle is solely supplied by median nerve? Flexor pollicis brevis, abductor pollicis brevis, opponens pollicis. Abductor pollicis brevis is solely supplied by, but all the other muscles have cross innervation. Flexor pollicis brevis has the highest number of cross innervation. So you check the APB. How do you check the APB? Abduction is this. So you ask the angle, ceiling factor ussanna. දැන් මම ඇඟිල්ල මේ තරකුණා මගේ මේකට විරුද්ධව සීලින් පැත්ත උස්සයි. මේ පැත්තට උස්සන්නේ විදිය මේකට උස්සයි. Power seems to be all right. Power seems to be all right. That is median nerve. Then what? Ulnar nerve. Ulnar nerve is Froman's test. How do you do Froman's test? Adductor pollicis. මේක තද කරලා අල්ලගෙන මේ කාඩ් එක මට ගන්න දෙන්න එපා. හරි? Is this performance positive or negative? Negative. So you have to always apply the same counter pressure. මෙයාට මේක අල්ලගන්න කියලා මම මෙහෙම ඇත්තොත් obviously මට ගන්න පුළුවන්. Apply same counter pressure. Right? What is positive performance? Let's say මම මෙහෙම අල්ලගන්න කියනවා. You hold it. You pull it. What is positive performance? Let's say my adductor pollicis is not working. Huh? No. To keep it in, there's a trick movement. My flexor pollicis will flex. My adductor pollicis is not working. My flexor pollicis will flex to keep the card in. So positive performance will be something like this. Card එක මෙහෙම පැත්තකින් ඉන්නේ එළියට. That is Froman's test. Then what? Radial. How do you check the radial nerve? How do you check the radial nerve? Angle පල්ලෙහාට නමන්න. Then දිගාරින් finger extension. Angle නමන්න. දිගාරින් finger extension. Right? Finger extension or even a wrist extension. So I have checked all three nerves. Then මම මෙතන සතු කරාම දැනෙනව නේද? ඔව්. ඇස් දෙක පියාගන්න. මම මෙහෙම ටක් නෙවලා. You all have a toothpaste. Huh? No. දැනෙනවද? ඒ වගේම දැනෙනවද කියලා. දැනෙනවද? දැනෙනවද? ඇස් දෙක වහන්න. දැනෙනවද? එකම වගේ දැනෙනවද වෙනසක් තියෙනවද? එකම වගේ දැනෙනවද? දැනෙනවද? එකම වගේ දැනෙනවද වෙනසක් තියෙනවද? එකම වගේ දැනෙනවද? එකම වගේ දැනෙනවද වෙනසක් තියෙනවද? එකම වගේ දැනෙනවද? එකම වගේ දැනෙනවද වෙනසක් තියෙනවද? So I'm checking C6. I'm checking the ulnar nerve, I'm checking the median nerve. Why did I check this side? Median nerve is this. I checked on this side. Why did I check on that side? What is the supply of the median nerve? What is the supply of the median nerve? This is the supply of the median nerve. Right? May the median nerve supply now? No, this is radial nerve. But we check here because of the cross innervation. Why did I check on this side? If let's say a patient has paralysis on this side, numbness on this side, and also on this side, what does that indicate? It is not a median nerve problem. It is the C6 nerve root, because this is both sides. Although this is median nerve, this is radial nerve. It is C6 root. Can you all remember? C3, 4, 5, 6, 7, 8, T1, T2. So this is C6. Although it is by two different nerves in the periphery. So if the patient has this and this both, that indicates it's not the median nerve issue, but it's a C6 issue. Okay. It could be cervical rib. Right. So that's why I check both sides. So at the exam you check this and this other nerve, and you make sure it's compare both sides are same, and also check this side. Right? Okay. So that's the sensor. Then only I check the pinals and the phalanx. I'm going to cut to the current type again. Yeah, you have to do it properly. Stretch it. Current type again. Get it. Right? That is the Tinner's test. Phalanx test. It takes some time. You use that side. Bell haran me pettara. Me bell kumake mukutiyana. Ne. I'm checking for bone lungs suggestive of cervical rib. Cervical. Then මොකද අත් දෙකට වෙන්නේ? It's a positive phalanx test. So while she is doing the phalanx, I am going back and examining for the neck movements just to see if there is a restriction. I am examining the posterior cervical, posterior triangle for bony lumps, suggestive of cervical rib. Okay, clear? Okay. To repeat, history, age, duration. What is the complaint? Numbness or motor, numbness or pain, radicular pain. මේ වෙලාවට ටේක් ඕවර් කරන්න නැහැ කියන්නේ හෙට උදේ වගේ කියලා. හෙට උදේ වගේ 4න් පස්සේ. මේ හෙට උදේ ටිකට් එකත් එක්ක වගේ අර ගන්න. හෙට උදේ ටිකට් එක ගන්න කියන ඒතර ගන්නවා. 4න් පස්සේ ටේක් ඕවර් කරන්න නැහැ කියන්නේ දන්නේ නැද්ද කියලා අහන්න. Right? Pain, numbness, hand dominance, radicular pain, risk factors, diabetes, hypothyroidism, arthritis, fractures. Okay? Then examination, inspection, previous scars, dorsal guttery, compare two thinner eminences and so if the thinner eminence wasting. Okay? Even you can check the hypothenur like this. And then we examine each and every nerve. Motor, abductor process brevis median nerve, Frohman's test for ulnar nerve, finger extension for radial nerve. Then check the touch sensation on both sides of the palm, ulnar and the median, and also on the dorsal side of the thumb for the radicular C6 renal root compression. Right. So then finally you can give a diagnosis. This patient clinically has, and then Tinner's and the phalanx test. This patient has clinically carpal tunnel syndrome on the right hand side, which is the non-dominant hand for him. What will you do? Then what will you do? They have to examine. What will you do now? You're 100% sure about your diagnosis. Or you want to do nerve conduction study? Better, no? Play safe. Nerve conduction study. Have you all seen nerve conduction studies? We have read. What are the parameters we check? What are the parameters we check? We compare both ulnar and the median of the same hand, both motor and sensory. We check latency, conduction velocity, and amplitude. You have never gone through a report. So we check the amplitude, conduction velocity, and the latency. So by that only you give the final report. And we check both motor and sensory for both median and ulnar. We come right. If you are suspecting cervical rib, what is the X-ray? Just X-ray. Huh? Swimmer's view. And then so Mr. Kimban, C81 junction la mein X-ray thoracic inlet view. If you want to see the cervical rib, X-ray thoracic inlet view. Even if you order a AP cervical X-ray, you will get it, but ideal X-ray is X-ray thoracic inlet view. Okay, then you get a nice piece area. Right. So then you will offer surgery. What is the surgery, Satrika? Carpal tunnel decompression. So she is awaiting right side carpal tunnel decompression. Okay. What is the mode of anesthesia? Local anesthesia with avascular field by a tourniquet. Any other mode of anesthesia? Can we do it under general? Yes. Those is spinal because it's hand, general or local. Any other mode? Huh? Regional. What do you call that? Beer's block. Beer's block. Okay? But don't say that at the exam, then they might ask about Beer's block. You can do it under Beer's block also. What is the problem with local anesthesia? What do you tell the patient? Patient has to bear the tourniquet pain. There will not be any cutting pain here because you have given local anesthesia. But we are putting a tourniquet 100 mm mercury above systolic blood pressure and keep it for at least 10 minutes because this surgery minimum takes about 10 minutes. So imagine this area is compressed for 10 minutes, you think it's easy. No, there will be tourniquet pain. Right? So to tell the patient, you will not feel any pain here, but there will be a tourniquet pain here which you have to bear up. Okay? Otherwise, the patient says no, yeah, you have to go for general. Still you have to do general with avascular field, with a pen. So, but there are certain instances, carpal tunnel decompression, you have to do it under general anesthesia. Example, is a recurrent carpal tunnel, because it's not easy. Recurrent carpal tunnel takes some time. So, we can't expect the patient to bear up the tourniquet pain for half an hour. It's unethical. Right? So, if it's a recurrent carpal tunnel, we do it under general anesthesia with a tourniquet. If it's a carpal tunnel syndrome with rheumatoid arthritis, we do it in general because there the architecture is not normal. Sometimes you have to do synovectomy also. So therefore it is preferably under general. If it's a carpal tunnel syndrome with carpal tunnel compression is due to some lump, let's say lipoma within the carpal tunnel. Again, you have to do it under general anesthesia. Persistent of fractures, better to do it under general because it takes time. Patient can't bear up the local anesthesia pain, tourniquet pain. So those are the indications of general anesthesia. Before surgery, what will you tell the patient with regards to symptoms? I will tell you 3 symptoms: pain, motor weakness, sensory loss. With regards to these 3 symptoms, what will you tell the patient before the surgery? What will you tell about the pain? Will the pain disappear after surgery or not? Pain disappears. What will you tell about the paresthesia? Disappears, but it takes time. What do you tell about the motor weakness? It doesn't disappear, it will be the same. Can you reassure the patient that your thin anus will be nicely bulged up after surgery? No, it's gone. It's gone for 6. You can't recover it. Okay? So you will tell, depending on the patient, what like it takes some time, but if there is motor weakness, no, it will not recover. Right? So you do this under anesthesia and carpal tunnel decompression. Following the surgery, patient complains of severe pain. Let's say after 2 weeks of surgery, patient says, I still have the pain. What are the possibilities? Cutaneous nerve. Neuroma. One is neuroma. Because during surgery you have caught a cutaneous nerve, palmar cutaneous nerve, then there is neuroma. That's one. Anything else? More than that? Divide kalla nahi. Yes, very good. Inadequate division of the flexor reticular. We have to completely divide it. Okay? But it's an inadequate division. That's another. Very good. Anything else? Wrong diagnosis. What could be the other diagnosis? We have done carpal tunnel decompression for cervical radiculopathy. You think the pain will be subside? No, pain will be there even after surgery if you are done it for wrong diagnosis, right? So that's why nerve conduction is important, right? Anything else? Another one for double crush. That means patient has both. Patient has carpal tunnel syndrome also, and also there's another one, right? So rare ones. So commonly in an incomplete division or wrong diagnosis, it could be a double crush, or it could be a neuroma, or it could be. Now we generally advise the patient not to do strenuous work with his hand within first week of surgery, because if you do strenuous work, there will be a lot of tissue edema here, and then patient will have prolonged pain. So other possibilities, patient has done strenuous work after surgery. Usually they don't do. So how will you advise a patient when you discharge? Have you ever seen post-carpal tunnel syndrome patient? What do we do after surgery? We suture and then we apply a cotton and crepe. Because we do it under a tourniquet to make it a vascular field. So we do it, finish the surgery, suture the skin, apply the crepe, then only we remove the tourniquet. Why? For the hemostasis. We apply the, because we expect only capillary bleeding, we don't cut major vessels, right? So we apply cotton crepe. So generally we ask the patient to keep the hand elevated for first 24 hours, because after surgery, if the patient keeps the hand like this, there will be dependent edema and then there will be problems. So that's one advice when you discharge. Okay? And if you can also tell the patient, if the cotton and crepe is too tight for you before discharge, get it little bit loose after 1 hour by the nursing officer, and then before you go home, right? Keep the hand elevated. And then suture removal on day 2 weeks, 14 days. And patient can do light work, not strenuous work. Maybe she can comb her hair from that, she can sweep the floor, but not to carry heavy market gear bag. So those are the advices. How do you make the incision? Now this is the distal wrist crease. Right? Carpal tunnel is here. These are the landmark. Carpal tunnel is here. Right? The distal wrist crease. And this is the fully extended thumb. If you make arbitrary line along the fully extended thumb, it will be like this. This is called Kaplan's line. An arbitrary line joint running across the fully extended thumb is called Kaplan's line. Right? So your incision should not cross the distal wrist crease. If you cross the incision along the perpendicular wrist crease, there will be contracture. You should never cross like this. Right? You should never put incision crossing any of these regions, then there will be contractures. So you should not cross this. You should not cross the Kaplan's line because your superficial palm arch is there. If you make an incision right up to here, during surgery you are bound to damage your palm arches. Right? When you are doing it under tourniquet, you will not even see the damage. So you put a tight cotton and crepe bandage and release the tourniquet and discharge the patient. Patient will bleed inside, large hematoma, huge problem. Right? Patient will not have ischemia because there are other farmers, but there will be a lot of problems. So you should not cross the Kaplan's line, you should not cross the distal. So that is this direction. What is over this direction? This is the ring finger. This is the radial border. This is the ulnar border. It should be along the radial border of the ring finger. So your incision has to be like this. It should be within this and within the radial border of along the radial border of the ring finger. Why along this line? Because when you put it on this line, there is a less chance of damage of the pharmacutaneous branch of the median nerve. More than that, what is the muscular branch of the median nerve? It's called recurrent branch. Recurrent branch. So if you go along this line, there is a less chance to damage the muscular. If you damage the muscular branch, I mean you are worsening the condition. You are making this you are denervating the muscles. So if you make the incision along the radial border of the ring finger, that is to avoid damage to the muscular branch or the recurrent branch, you are keeping within the Kaplan's line to avoid damage to the superficial palm arch, and you don't cross the distal space to prevent contractions. So you have to make the incision on this. Okay. So now you know everything about carpal tunnel. Okay. So now make a short note, make a card, and then that's how you remember for carpal. No, this. What හඳුනන පුළුවන් නේ වල ඒ වටල කරන්නේ ඔව් මොනවද 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 ගෙනන්නේ මේ ඉතිරි වටල කරන්නේ